everybody, and happy Saturday to you, wherever you are calling in from. We heard that there are many people from all over, and we are always excited every Saturday because we do these calls for training purposes. And because as a ZInzino partner, we're very excited about the mission that we're on and really making a difference in world health. And so this week we're in such a treat because we have a fantastic speaker on today that we're very proud of. His book by Dr. Paul Clayton, Let Your Food Be Your Pharmaconutrition. And this is something that has changed myself and my family's life. And we've become very passionate about what we're doing here in ZInzino. And actually, he has been on the Senior Scientific Advisory Board for the UK government's Committee on the Safety of Medicine. And he's been the chair of the Forum on Food and Health of the Royal Society of Medicine. I mean, not only that, there is a line of things that he has done in his life because of his passion to make a difference in world health. And we are so proud that he is a senior scientific advisor for ZInzino. So let's bring him on here to talk about one of the most important and hot topics that we have out there right now, our gut health. And a lot of people think, well, if you're just looking at somebody, you're going to be able to tell, but your gut health is something completely different of what's going on in there and what we can actually do about it and how important it is to know your gut health. So bringing on here Dr. Paul Clayton. Dr. Paul, we're proud to have you here. Hello, Dr. Paul.
I'm delighted to be with you, and I'm astonished that it's such an international audience.
Yes, actually, Dr. Paul, you always pull in a lot of people from all over because of your passion also for making such a difference in the world. And that's one reason that we enjoy following you and listening to all the science behind what ZInzino is doing, because it's one thing just to say that this is good for you. It's one thing just to say this is, something that's good for your body and your health, but to have the science behind why it's important and what we're doing to fix the problem, that's where you come in, Dr. Paul. So we're so proud to have you on. And I know that this is something that you're also very passionate about.
Well, yes, passionate, but passion is a word that scientists are very cautious about. Yes, it's important to have a reason to do what you're doing. And I'm motivated very much by the terrible state of public health that we see around the world today, and by the terrible politics that has allowed this situation to develop. So passion is one thing, but when it comes to the science, you have to squash the passion. You have to remove it from the equation. You have to learn to look very carefully at the data, to develop ideas and hypotheses based on that data, to test those. And, even if you feel strongly about one particular idea or model, if a piece of information becomes available that can't be fitted into your model, no matter how strongly you feel about it, you have to let your model go, or at the very least amend it. Passion can be blinding, and a lot of the training that any scientist has to go through is to do with removing yourself from the equation, to not impose your emotions on what can be very complicated and unruly sets of information. So I'm going to put the passion aside for today. I put that on display in my blog sometimes. And what I'd like to do is to, first of all, give a presentation, show some slides, not too many, about gut health and how it impacts on every other system in the body. And hopefully, if there's time, at the end of this, then we can do some relatively free-form questions and answers, because I'm sure that the audience will have various things that they want to talk about and discuss, and I'll try and respond wherever I can. So may I just now share the screen and go through some slides with you?
That sounds absolutely wonderful, Dr. Paul. And I think it's okay to set the passion aside and really get the facts and to tell us how important this gut health is and the science behind it.
Very well. Well, I'm going to talk about the gut and gut health and how it impacts us. But what you find out very quickly when you start looking through the available information is that everything connects. So the gut, I think everybody knows by now that it connects to the brain. Everyone's heard of the gut-brain connection, but it also connects to the placenta, the gonads, the heart. It's involved now, we now realize, with a lot of the confusion that's going on about gender. Why is it, for example, that so many children now feel that they may or may not be a different gender other than the one that they were born into? And it turns out that what's going on in your gut is almost certainly affecting that as well. And a little bit of German there, which I know that any Germans, and of course the Dutch, the Netherlanders who are in the audience will know what this means. Alles verbindet, and that's actually derived from something that Ernst Haeckel said. He was a 19th century biologist who was very important, whose work was rather overshadowed, but he was the first monist. He was one of the first people who said, well, hang on, perhaps we shouldn't be thinking about different systems. Perhaps everything does connect. And everything that we've learned over the last century has led us inescapably to this conclusion. Everything does connect. And when you talk about gut health, it's important not to talk about it in a vacuum. It's very much part and parcel of total health. And I want to start off by trying to put this in a historical context. And because you can't really talk about gut health without talking about diet and specifically to do with prebiotic intakes, I thought I'd surprise you all with some very interesting work that has been done that has quantified or tried to quantify prebiotic intakes at different periods in time before the 21st century, where we're obviously in such a mess. Now, if you go back to the times BC in Mesoamerica, and this is Middle America, it's that isthmus that joins the American continents, there is a group of Amerindians who've been very well characterized. They're called the Oda or the Odom people. And based on an analysis of their architectural remains, what we know of their agricultural practices, we know that they're eating around 135 grams of prebiotic fiber a day, which is a huge amount. It's about a quarter of their total calorific intake. And we know what it was derived from: agave, beans, maize, and nopales. This is all very well characterized. If we come closer to the modern day, to the 19th century in Britain, and this is another population that's very well characterized, better, I would say, than the Mesoamericans. We know that they were consuming between 20 and 40 grams of prebiotic fiber a day, so not quite as much as the Mesoamericans, but still very significant amounts. Where are they deriving it from? One of the staple foods in the second half of the 19th century, a period that we call the mid-Victorian era, is something called Helianthus tuberosus, and you may be more familiar with that as in its vulgar name, the English name, which is the Jerusalem artichoke. This is a root vegetable. It looks a little bit like a mutated potato, very irregular, but it is full of prebiotic fiber, specifically phos and inulin. And they also ate very large amounts of different types of legumes. So, for example, pulses and beans and things like that. This is a pretty good estimate, 20 to 40 grams of prebiotic fiber. How do we do today? Well, the best data that we have, and this is taken from North American data sources, they're consuming very little fiber indeed, and Europeans actually aren't that much better. Total intake of 15 grams of fiber, and only about a quarter of that is prebiotic fiber. So today, average consumption of prebiotic fiber, which you need in order to support the good bacteria, is 3.5 grams. So the point that I want to make is here that if you look at this in using a long lens, we have declined, our intake of prebiotic fibers has declined very, very dramatically from 135 grams to 3.5 grams. That is that's an extraordinary shift in our intake of one particular class of nutrient. And I think that the evidence is now so strong, linking these fibers to overall health, that I think that we can now legitimately call them essential nutrients. So our intake of this group of essential nutrients has declined from 135 grams to 3.5 grams. What impact has this had on the microbiota in the large intestine? Well, first of all, you have to take into account what are those fibers actually supporting. They are the exclusive growth substrate for lactobacilli and bifidobacteria. Those are well-known probiotic species, but not just those two. Those are the ones that everybody knows, but there's a whole bunch of others. I've just selected three almost at random. These are three more. All of these are gram-positive. They all utilize the prebiotics, which are structural carbohydrates. All of them break them down. All these species are associated with all kinds of positive health outcomes. These are all probiotics, even although the last three of them are not particularly well known. And all of them break down prebiotic fibers into short chain fatty acids, including butyrate and propionate, and I'll come back to that later. But they also produce bacteriocins, which are antimicrobial compounds. So the more you feed these good bacteria, the more bacteriocins they produce, which kill off bacteria that you don't want, many of the gram-negative bacteria. They also are very good at killing off mold species, such as Candida, which you don't want. So the more of the good bacteria you have, the less of the bad bacteria and other unicellular species. These good bacteria are also producing microsomal mRNA, which is quite interesting and actually rather important. I don't know if we'll have time to go into all of that. And some things which are called MAMPs, and these are microbial associated molecular patterns, and they have a huge impact on the functioning of your innate and adaptive immune systems. So if you're eating lots of probiotics, you have lots of the good bacteria, and they're producing lots of mediators, which have knock-on effects on other aspects of the microbiota, but also on your immune system, your cardiovascular system, your central nervous system. The list goes on and on and on. And when Hippocrates said very famously that the root of ill health was in the gut, and the converse was also true, I would say that he was far more correct than he could possibly have known. All the research that has been done over the last half century or so, it has done a great deal to support this particular statement of Hippocrates. So if we look at this again in a historical perspective, traditionally, because we've always eaten so much prebiotic fiber and we've encouraged the growth of these gram-positive species in the gut to such extent, the traditional microbiota, and you still see this in vestigial cultures today, it was characterized by gram-positive dominance. You had more gram-positive species there than you had gram-negative. The problem is, as these prebiotic fibers have been removed from the gut, the good guys, the good bacteria have been starved, they've diminished in numbers catastrophically, and their place has been taken by a number of other species, predominantly gram-negative species, such as Bacteroides. And in that same period, what we have seen is a huge increase in the non-communicable degenerative diseases, about a 10-fold increase. And I think the question we have to ask is, well, is there a link? What I'm going to show you over the next few slides is the idea that there is not just one link, that there are multiple links, and that we can actually trace using a kind of pharmacological or mechanistic perspective, we can make some very direct connections between the reduction of prebiotics, the change in the microbiota, and the enormous and diverse decline in public health that we've seen, particularly over the last half century. This was brought into, I think, very sharp relief by a huge meta-analysis that the World Health Organization carried out in 2019. And I know that many of you have rather negative views about the WHO, which is actually being run by a war criminal at the moment. And I have rather I'm very conflicted about the WHO myself. In general, I'm not supportive of most of its current political aims, but they did support this one study, which involved a number of scientists who I respect and some of whom I know personally. So I tend to believe this data. They came up with this idea that if you are eating higher fiber intakes, this was enough on its own as a single category of nutrient to reduce early, which means unnecessary or avoidable early death by 30%, which is huge, really, really huge. And they broke this down. Then they said, well, what you see if you increase your fiber intake is reduction of bowel cancer by 25%, breast cancer 20%. And I'm going to come back to these things a little bit later in the slides. You reduce the risk of heart attacks and strokes. Other people then looked at some of this data and revisited and said, well, you also protect against dementia. You protect against non-alcohol related fatty liver disease, which is really prevalent now, currently affecting 1 in 4 of the world's population and projected to affect 1 in 3 of the world's population by 2040. And you also, if you have higher fiber intake, you have better COVID outcomes. So if you have lower fibers, you have worse COVID outcomes. You also, if you're having a higher fiber intake, there is a degree of protection against Parkinsonism and Alzheimer's. And we think that there are certain types of gram-negative sulfate reducing bacteria that are involved here, but probably others as well, and a whole range of other pathologies. So getting the microbiota right does seem to be extremely important in terms of a whole range of health outcomes. And this was really a large study, very, very big numbers, very powerful and very significant data. It's not a good idea not to eat very much fiber. This is what's actually happening in the large bowel. If you're eating a large amount of prebiotic fiber, which we always used to do, you're supporting the growth of gram-positive saccharolytic species. I'm sorry about the jargon, but I think quite a lot of you have science in your backgrounds or you're practicing scientists. The prebiotic fibers are carbohydrates. We can't digest them. They pass intact into the large intestine where they are metabolized by these gram-positive species that use them as fuel. Now, because when the prebiotic fibers enter the large intestine, they're in the contents of the gut. They're in the lumen, in the center of the gut. So that's where the gram-positive bacteria tend to migrate. They go towards the center of the gut where the fibers are coming in. They break those fibers down and they produce short-chain fatty acids, and they can produce here, as you can see, AMPs. You can see in the top left of the picture, those are the antimicrobial proteins I told you about. Under these conditions, you don't really have very much contact between the overwhelmingly gram-positive bacteria and the colonocytes. Those are the cells that line the bottom of the picture. But there is some, and the microbe-associated microbial patterns that you have on the cell walls of the gram-positive bacteria are just tickling, the immune cells that you have in the lining of your gut. And the gut then responds with a kind of very low level, but entirely appropriate. It's physiological, it's a healthy level of immunological surveillance, low level inflammation, physiological inflammation. And the gut cell then, or the cell walls, then start to produce something called interleukin-18, which is really important in just keeping both the innate and the adaptive immune system ticking over, talking to one another properly, improving your overall ability to resist infection and not be allergic, amongst other things. So this is what's happened. The prebiotic fibers have been taken away. The numbers of your probiotic species, the green microbes, have been dramatically reduced, and their place has been taken by gram-negative microbes. Those are the little ones in red. Now, these do not use prebiotic fiber as fuel. They're actually proteolytic. And where do they find protein? They find it in the mucosal layers that line over the colonocytes. And because they're actually eating the proteins in the mucosal layers, they break the mucosal layers down and they come into direct contact with the colonocytes, our cells. Those are the cells, as I said, at the bottom of the picture. And because these are gram-negative microorganisms, they are coated in lipopolysaccharides. That's what makes them gram-negative. And lipopolysaccharide is one of the most pro-inflammatory compounds that we know of. So now suddenly the cells that line the gut are not being stimulated in the right kind of way. They're not producing immunosurveillance. They're not producing a physiological level of inflammation. They are producing an extreme pathological level of inflammation, and they're pumping out inflammatory mediators in all directions, including something called LL37 and IL-18. And the worries that we have about these are, first of all, that they're involved with tumor progression. And now you can begin to see how having the wrong kinds of microbes in the gut might lead to an increase in cancer, as the WHO study showed. But you also find that these particular molecules, and one or two other things as well, are causing something called neuroinflammation. And neuroinflammation is something that you really don't want to have because it brings all kinds of problems in its wake. So first of all, you've got local problems because you've got the wrong population of bacteria in the gut, and IBS, which was really only characterized for the first time around about, I would say, you see the first descriptions of this, or what could be this, entering the literature in about 1940 or 1950. IBS is a condition that's hard to diagnose. We don't have any reliable markers. You tend to make your diagnosis based on a clinical assessment. It's not always it results in hospitalization. The records available that we have, if we want to analyze incidents, are not particularly good. But the best data we have suggests that this particular problem, which hardly existed 50 or 60 years ago, it is now affects up to 14% of populations in the West. If we look at the more serious conditions of IBD, so you're talking about ulcerative colitis and Crohn's and things like that, the evidence is very clear that pediatric IBD is increasing almost everywhere you look. And adult IBD is rising, particularly in those countries which are newly industrialized and which are moving into a post-transitional kind of a diet. That is where the intakes of prebiotic fibers are basically falling off a cliff, and the microbiota is changing as a result. SIBO, you know, I can't quote you chapter and verse to say that SIBO is increasing because it hasn't been recognized for all that long of a period of time. Diagnosis isn't always very accurate. We do know how to diagnose it, but it isn't always well diagnosed. But it looks from the available data that SIBO is probably also increasing. I would be very surprised if it wasn't, because one of the things that we know increases SIBO is an intake of antacids, because bacteria can get through the gut, through the stomach, which is no longer producing enough acid to kill ingested microbes. They're getting to the small intestine. But also, if IBD is increasing, you get ileocecal valve scarring. The valve itself becomes less functional, and now you're getting microbes passing retrograde from the large bowel up into the small bowel. So IBD, so SIBO, I think from the people that I've talked to, I think it is increasing as well. But again, I would say I can't give you chapter and verse on this. Now, colorectal cancer, on the other hand, is most definitely increasing. And if you look at the rate of increase, it's actually quite staggering since 1995. So in the last quarter century, in young adults, the incidence of colorectal cancer has doubled. And not only that, but what my colleagues are seeing when these younger people are presenting for the first time is that in very many cases, the colorectal cancer has progressed to a far greater extent than they would have seen as a quarter century ago. So where people were being picked up with stages 1 and 2, they're now being picked up with stages 3 and 4. So something terribly wrong is happening locally inside the gastrointestinal tract. And the impact on the liver, this enormous increase in NEFLD, which of course is draining the intestines, all the blood supply, the venous blood from the intestine goes initially to the liver through the portal vein. So all the toxic stuff that's happening in the colon is going to be impacting on liver health And this is certainly one of the reasons why NAFLD has gone up in the way that it has. Now 1 in 4, projected to hit 1 in 3 by 2040. Systemic issues, well, cardiovascular, well, yes, if you're pumping out a lot of inflammatory mediators from the gut, including LPS itself, which actually escapes the gut and gets into the bloodstream, a condition that we know as endotoxemia, of course, you're going to have more endothelial dysfunction, which means more hypertension, which means more coronary artery disease and stroke, and that's what the WHO studies showed. And because you are pumping out these pro-inflammatory tumor enhancing or cancer enhancing messenger substances, you see an increase in breast and prostate cancer. Now, there's some other things as well. That's not just pro-inflammatory, there are endocrine changes as well. And I'm going to come to that again later. Now, endotoxemia, I mentioned a minute ago, this is what happens when you have really intense inflammation inside the large bowel. What happens is that the colonocytes start to separate, and you get a breakdown of normal colonic epithelial barrier function. So things that should remain in the gut are actually beginning to escape into the bloodstream. And one of those, a subset of those are small molecules or even large molecules like lipopolysaccharide, gets into the blood. That is what endotoxemia is. Its compound is highly pro-inflammatory. Now you're setting up foci of inflammation everywhere else in the body. But if the inflammation gets bad enough, you actually also get the translocation of microbes. Microbes can get out through the holes in the gut wall, move into the blood system, get elsewhere, and then not necessarily set up directly and obviously clinical infections, but we now know that that's involved in a lot of the increase in autoimmune disease that we've witnessed over the last generation. And it also is involved in a huge increase in toxic preeclampsia. And I'll come back to that later. Now, neuroinflammation is pretty bad news because if you have neuroinflammation, you get excessive microglial pruning. Now, your nerve, your central nervous system is incredibly dynamic. Every time you learn something, you forget something, the synapses are growing and forming, and they're being pruned back all the time. The brain is a very dynamic organ, not static at all. And the ability to think, to learn, to be Homo sapiens, and I'm using the Latin here, this is not a gender-related or a cultural issue. Your ability to be sapient depends on your ability to form and break down new synaptic connections. I'm not going to get into the synaptic coding of memory and consciousness. That's a whole different area, which is interesting to talk about, but we don't have time. But if you have excessive microglial pruning, you're going to be more stupid. You'll be less intelligent fundamentally. And that's going to have an impact in the short term, but in the longer term, it's going to increase your risk of neurodegenerative disease. And if you have neuroinflammation in utero, you are more likely to develop a neurodevelopmental disorder. If you have it as an adult, you are more likely to develop a neurodegenerative disease and to lose IQ points. So you don't want to have chronic neuroinflammation. Another reason why you don't want to have chronic neuroinflammation is that you're going to have more pain. Now, the frequency of chronic pain is also increasing all around the world. And if anyone is interested in this, by all means, visit my blog. I wrote a post on this not too long ago. And there are cultural determinants here. There's all kinds of other factors that play a role. But the numbers of people in chronic pain for whom the medical profession is unable to provide adequate support are undoubtedly increasing globally. Affective disorders, including anxiety and depression, very much involved. If you have neuroinflammatory stress, you have those inflammatory disorders, you have sickness behaviors and reduced performance, and I'll come back to that a bit later. If you have chronic inflammatory stress for too long, then this pruning back of microglia and the pruning back of synapses will eventually culminate in the retrograde axonal degeneration and cell death. Now, two things are happening here. Firstly, you're getting a direct attack on the structure of the nerve cells themselves, which will eventually kill them. But the other thing that's happening is the brain is almost, I think it's between 25, it's about 25, 28% by weight connective tissue. Yeah, I know you haven't come across that before, but when you think about it, there's no structural landmarks inside the brain. There's no bones, there's no sinews. What there is a very large amount of extracellular matrix, which is this very diffuse structure. It's a microfiber matrix, a three-dimensional matrix. And what holds the different neuronal structures together that allows the brain to function as it does. If you have chronic inflammatory stress, this extracellular matrix is also being degraded. So not only are you directly killing off brain cells, you're actually destroying the microarchitecture of the brain. And you're therefore impinging on central nervous function in two very, very important structural ways. And this is probably why, if you have IBD, which means almost by definition, you have serious dysbiosis, you have an increased risk of the neurodegenerative diseases, including dementia and Parkinsonism. And if, as I said, you're exposed to this kind of neuroinflammation while you're in utero because your mother is eating the wrong kinds of foods, the modern diet, if she's subject to social defeat, we can get into that too in the questions and answers if you want, then you have a significantly increased risk once you leave the womb of autism and schizophrenia. I will only say in passing that neuroinflammation also plays a role in seizure threshold. So if you have neuroinflammatory stress, you're more likely to have epilepsy and to have more fits and more serious fits if you do. But it also makes you more vulnerable to trauma-related brain damage. So if you're someone who's involved in contact sports and you have neuroinflammatory stress, you're going to lose brain cells very quickly. If you don't have neuroinflammatory stress, you'll actually be able to withstand being knocked about on the rugby field or the martial arts ring or cage, if you're that way inclined, and you probably won't develop brain damage. In fact, humans were designed to live a hard-scrabbled, knockdown lifestyle and not develop brain damage, and previously we didn't. It's the modern diet that has left us so vulnerable because it has left so many of us with neuroinflammation. So what's happening, what's connecting the gut with what's going on elsewhere in the body? Well, lipopolysaccharide, I've mentioned that, pouring into the blood, causing endotoxemia, risk factor for all kinds of problems. If you have the right bacteria, you're flooding your system instead with acetic acid, propionic acid, butyric acid, and these are really important, very, very good for you. They support health. They kill cancer cells, they're anti-inflammatory, they protect against neuroinflammation, as does molecular hydrogen, which you also produce in the gut if you're eating prebiotic fiber. Molecular hydrogen is a very rapidly diffusing and very effective antioxidant, and this will protect you against excessive oxidative stress as well. The right bacteria, if you're feeding them, are going to be producing polyamines, so spermine, spermidine, putrescine, and all the rest of those. And that's really important because they're local tissue growth factors, so they're involved in healing. If you have been injured, then you're going to heal more quickly if you have the right microbiota, because you're producing more of these growth factors. They're involved in all kinds of other modifications which have multiple effects in all tissues. And in addition to the transmission of sort of low molecular weight factors, you also have traffic from the gut to other tissues of a more complex sort. For example, in the vagus nerve, where we know that there's a retrograde transport of various enteroviruses, which are very linked to Parkinson's disease, as well as the sulfate reducing bacteria that I mentioned. Parkinsonism it's not a disease, it's a syndrome. If you look at the astonishing complexity of what's going on inside the brain, inside your neurons, inside your glia, it's very clear you can end up with something that looks like clinical Parkinsonism from about 200 different starting points. So it's not all viruses, it's not all bacteria. There's other things that are going on here as well, but those are just two linked here. The alpha-synuclein risk factor, which I'm sure some of you have heard of, is linked to dysbiosis. And other metabolites is hydrogen sulfide, which is produced in the gut. If you're not eating prebiotic fibers, you're going to produce more hydrogen sulfide because you have sulfate reducing bacteria in the gut. Hydrogen sulfide is extremely corrosive, but it is also a grade 1 carcinogen. So you really don't want to be going down that particular metabolic route. And then microbial translocation. So it's not just compounds, it's not just viruses, it's pathogens of different sorts, which are escaping the gut where normally they could be kept under control. They wouldn't be harming you too much. But what some very elegant experimental work has shown is that if you allow these microbes to escape from the gut and get into peripheral tissues, they will get inside the cells in some of these peripheral tissues where your immune system cannot reach them, but the cells that contain them will express fragments of these microbes on their cell surface, which the immune system can recognize. And if those cells are in the beta cells in your islands of Langerhans, your immune system will attack them and destroy those cells, and you will develop type 1 diabetes. And if they're in cells which are in the synovial tissues in your joints, your immune system will attack them, and you will develop rheumatoid arthritis. And this is one of the reasons why we're seeing so much more autoimmune disease than we did a generation ago. The rates of most autoimmune diseases have been increasing by about 2 or 3% per year, every year for many years. So what are the range of CNS-related problems that dysbiosis is going to move you towards? Well, these are some of them. I'm going to quickly look at them in turn. Let's look at neurodevelopmental disorders and schizophrenia. We know that the neurodevelopmental disorders are increasing in all developed nations. In America, the increase has been spectacular. No coincidence that Americans eat the most ultra-processed foods and the least fiber. Schizophrenia increasing also. If you do the preclinical work and you expose, you're doing, your R&D and you're doing, say, rodent studies, what you find is that if you expose the mother rat while she's pregnant to certain inflammatory stimuli, then the offspring will develop not only neurodevelopmental disorders, but schizophrenia-like symptoms as well. And this, I think, is a nice mechanistic link between dietary change and the increase that we've seen in schizophrenia over the last clinical generation. What are the risk factors for neurodevelopmental disease and schizophrenia? Well, they include maternal obesity, diabetes, infection, and chronic stress, and all of these will increase the synthesis of inflammatory mediators, including interleukin-8, which is really under the microscope at the moment, but I don't think it's the only one that's involved. So there's your preclinical work, and endotoxemia is undoubtedly contributing. So get your microbiota in order. The affective disorders and pain, well, I mean, again, it's well known that depression and the anxiety states are all increasing. And we also see an increase in the numbers of deaths of despair, which I think is now well over 100,000 a year in the United States alone. So these are people for whom the exigencies and the pressures of life are just too much. They can't cope. We have become less resilient, and the microbiota seem to be very much involved here as well. Reported pain increasing also in children, and the microbiota are definitely involved here because not only do we have neuroinflammation, there's 3 different types of pain. Neuropathic, where you're getting deterioration of sensory nerve cells. Nociceptive, which is mostly caused by chronic inflammatory stress. And nociplastic pain. And nociplastic pain is the 3rd category, where we believe the increase in the sensing of pain is due to neuroinflammatory stress actually in the pain matrix, which is a complex neuronal network that links midbrain and forebrain structures, which is where you perceive and sense pain. So the connections here have all been mapped out. We know that various microbiota metabolites affect your local pain sensing nerves in the body. We know that they create neuroinflammation. We know they damage blood-brain barrier function. We know that they increase the sensitivity to pain. Epilepsy is the microbiota affecting epilepsy, or I suppose I should say are the microbiota. Please excuse my grammar. One of the first clues that this might be going on is a paper that was first published, I think 6 years ago. Since then, there have been more, showing that bariatric surgery increases the risk of focal epilepsy. Bariatric, which is weight loss surgery. Now, weight loss surgery causes all kinds of problems, I mean, including the well-known bariatric divorce. Bariatric epilepsy is less well known. And we now have the beginnings of an idea as to what the connection consists on. We know that if you have a reduced fiber intake, you will move towards gram-negative dominance, you will develop endotoxemia, and reduced butyrate formation. And butyrate is really important because it inhibits the enzyme histone deacetylase. And now, if you're no longer acetylating the histones around your DNA, you are creating epigenetic changes which directly lower the seizure threshold. And we know that butyrate is important because one of the well-known ways, nutritional ways of improving epilepsy is the ketogenic diet, which increases butyrate. So why does bariatric surgery increase the risk? Because if you eat bariatric surgery, you have to have very small meals very often. And if you look at the fiber intake, the fiber content of those types of meals that are recommended, it's practically zero. So you're going to have endotoxemia, your bloodstream is going to fill up with lipopolysaccharides, your butyrate levels are going to fall through the floor. Absolutely, you're going to have more epilepsy. So we've looked at pain, neurodevelopmental disorders, schizophrenia, epilepsy. What about intelligence? Well, first point to make is that the best data that we have suggests that since 1950, we've lost an average of as many as 10 IQ points, which is pretty bad news. And there's a certainly increase in dementia, with more to come. I'm going to quote now the ELSA Brazil study, which has just been published, which looked at the impact of diet on dementia incidence, which is very tightly related to IQ. And this quite large study found that the adults who consumed the most ultra-processed foods and were consuming the least prebiotics had a significantly faster rate of executive function decline and global cognitive decline. So their brains were being damaged. There's no two ways about that. And we know from other studies that the more ultra-processed foods you eat, the less prebiotic fiber you have, the more you see shrinkage and damage to the hippocampus. And the hippocampus is important because that's one of the few areas of the brain where you're continually growing and forming new neurons throughout your life. And they are getting up into the forebrain, and you need to keep on repopulating the forebrain because that's where higher executive function takes place, where a lot of cognitive stuff takes place. And if you are starting to degrade the hippocampus, it's structurally and functionally, your IQ is going to fall, and you're going to be more at risk of dementia. And the interesting thing is that we have this idea about hippocampal atrophy and dementia, but it's more and more likely to occur with age in Western populations, in industrialized countries. But recent work has shown, and this is from the some of the work that's being done by UCA personnel amongst the Tsimane in Bolivia, they have found that hippocampal atrophy doesn't really occur in vestigial groups of people, that is, people who eat the traditional diet. They tend not to get demented as they get older. Their intelligence doesn't decline. In fact, you know, the wisdom of the ancients, that's very much a cultural mean that has been with us. If you look through, you know, the cultural backstories in many parts of the world, it is the elderly who are considered to have the most wisdom. Not quite sure that that's true anymore, because we are eating a diet that ensures that as you get older, you're not going to get wiser. You're actually going to become more demented. And hippocampal health is really important. It's the key to memory encoding, mood regulation. It's damaged by neuroinflammation that stops hippocampal neurogenesis. If you have enough neuroinflammation for long enough, your hippocampus does atrophy, and then you're going to develop dementia and you're going to develop Alzheimer's. Before you get there, you're going to go through a whole series of sickness behaviors, because neuroinflammatory stress triggers something called the cell danger response. Now, the cell danger response is something, again, we have to put in a kind of evolutionary context to make sense of. Under what situations would you have developed neuroinflammatory stress in a pre-industrial age? And that would typically have been if you'd gone out and you'd become injured in battle or as an accident or whatever. Bacteria will get into the blood, you develop a systemic inflammatory response to that. And what happens? If you've been defeated, or you've been injured, you've been out on the hunt, what do? Well, what you have to do is you have to withdraw. You have to go to the back of the cave and hope that your body can heal. So what happens is neuroinflammatory stress triggers a series of behavioral responses known as sickness behaviors, and they include withdrawal, depression, loss of sociability, demotivation, risk aversion, and it's now also being implicated in anxiety and PTSD. And that's fine. That's if it's a short-term thing and your immune system works and you clear the infection, you recover, and you leave the cave and you go out and you participate once more in cultural activities of various sorts. But if neuroinflammatory stress is continued for longer, and it's no longer infectious, it's sterile, but it's caused by the modern diet, chronic inflammatory stress will then lead to initially memory problems and subsequently reduction in intelligence and over the longer haul dementia, which is what the modern diet and lifestyle is doing to us. A few more things before I wrap this up. And we'll talk quickly about polycystic ovary syndrome, preeclampsia, infertility, and gender dysphoria, which is a very difficult topic. If there's time, I'll get into periodontal disease. So let's talk about PCOS to begin with. A couple of Australian scientists, Tremelin and Pearson, I think, in 2012, were the first people to link dysbiosis to polycystic ovary syndrome. And I think their work was really beautiful. It's subsequently been supported by a lot of other scientists and other findings. And they had this idea, well, if you have dysbiosis, you're producing lipopolysaccharides and getting into the blood, you're causing inflammation, which leads to insulin receptor damage, insulin resistance, and then you have an impact on androgen production in the ovaries and you disrupt follicular development. And this story is looking very coherent now. It has quite a lot of support. And of course, I don't have to tell you that PCOS, the numbers of people, of women presenting with PCOS have far increased. I mean, compared to a generation ago, it's just, there's no comparison. Toxic preeclampsia. Are we seeing more of it? Not possible, I don't think, to say conclusively yes or no, because records in different countries aren't kept particularly well, but we're certainly seeing more early toxic preeclampsia occurring in younger and younger groups of subjects. It causes neuroinflammation, which causes neurodevelopmental disease in the young and brain damage, both in the infant and in the mother. The latest idea about toxic preeclampsia is that it is fundamentally a disturbance of placental blood flow. It is an incorrect placental physical and circulatory development, leading to chronic inflammatory stress in the placenta, whereby the placenta is now drip feeding inflammatory mediators into the maternal circulation, which then cause, amongst other things, hypertension and various behavioral problems. Now, I mentioned before that if you eat prebiotic fibers, you increase the good bacteria and they produce butyrate and propionate. And they're exactly what you need to make the placenta work properly. So if you're producing more butyrate in the gut, there's less inflammation in the placenta. If you're producing propionate in the gut, you improve the placental microcirculation. Conversely, take the fibers out of the diet, you have dysbiosis, and now you have impaired placental circulation, you have more placental inflammation, you're moving towards preeclampsia. And you also, now we know, because if you're getting microbes leaving the gut, you now have a dysbiosis in the placenta as well. So when we talk about dysbiosis, most people would say, well, it's all about, the bacteria in the gut. Well, the bacterial population in the gut is quantitatively the most important microbial population, but every tissue, every organ has its own microbiota, including the healthy placenta. But if you have colonic dysbiosis, you're going to have dysbiosis in every other organ as well. And that has now been shown to include the placenta, which probably makes this problems of placental microinflammatory stress much, much worse. Can I say definitively that eating prebiotic fibers is going to reduce the risk of preeclampsia and PCOS? Actually, I can't put my hand on my heart and say it's proven, but if I were to put money on it, I'd bet the farm on it. That's how good I think the evidence actually is. Infertility and gender dysphoria. Well, infertility, I mean, that again goes without saying. Sperm counts are falling off a cliff. Male infertility and female infertility are at record highs, and gender dysphoria is also at record highs, increasing dramatically. So let's talk about sex hormone formation, spermatogenesis, and sexual endocrinology, and the impact that this might have on gender confusion. Well, first of all, the most important point to make is that the gonads are immunologically privileged. What that means is they and a couple of other sites in the body are protected from the immune system because they're producing cells which are antigenically distinct from the parent, because they only have they only have half the number of chromosomes. So you have to protect them from the immune system. And the way that's done is that you create a situation within the ovaries and the testes where there is a very low level of inflammatory stress, which is actually an essential part, for example, in the testicles, both of testosterone synthesis and spermatogenesis. If you have chronic inflammatory stress occurring elsewhere in the body, it overwhelms this physiological level of inflammatory stress, and testosterone synthesis falls. And so does sperm counts. And the same thing happens in the ovaries. And what happens is that testosterone levels are falling in men. Androgens are being increasingly produced in women. And these are really important sex hormones. And amongst other things, they have an impact on the developmental of sexual secondary characteristics and brain development. They also affect, the way that you think and feel and perceive yourself. And these sex hormones are being moved all in the wrong directions by having dysbiosis, by not having enough prebiotic fibers in the gut. If you have PCOS, you have elevated testosterone. That's a masculine or a masculinizing hormone that's increasing in women. Testosterone is being reduced in men. And you also have serious problems with estrogen. Now, the estrobolome describes the total numbers of different microbial species in the large bowel, which have an impact on estrogen metabolism, excretion, and reabsorption. Now, if you have dysbiosis, which is now prevalent, you produce all kinds of bacteria which are pumping out an enzyme called beta-glucuronidase. And when that happens, then estrogen glucuronides, which would normally be excreted, they're broken down into estrogen, free estrogen, which is then reabsorbed. So your estrogen levels go up as well. And this is probably one of the reasons why puberty, the age of puberty, is falling in women. So this change in diet is having a very complex knock-on series of effects on the microbiome and then on your sexual endocrinology. And I'm not going to be, reductionist enough to say, well, this is the only reason for the increase in gender dysphoria that we're seeing. But I think it would be ridiculous to say it's not playing a role. And I will leave it at that because this is such a contentious and an emotive issue. Along with accelerated puberty, we're seeing increases in breast cancer, again, because of this a pathological increase in estrogen reabsorption and then estrogen levels. And interestingly enough, it looks as if the prebiotic fibers will be helpful here because they reduce the numbers of bacteria producing this glucuronidase and they lower estrogen, which is in many cases a very useful thing to do. So what do we do when you have this mess going on inside the large bowel? You simply add the prebiotic fibers back, you restore a physiological level of inflammation, you restore endocrinological normality. And here are some of the prebiotic fibers eventually that we actually use. And this is fructooligosaccharides, very small molecules. When probiotic species utilize these fibers, they eat them rather like beads on a chain. They break them down linearly. So they go fructose by fructose by fructose. And because these molecules are very short, this reaction, the way in which the bacteria eat them, technically it's a fermentation, is very rapid. So we will use larger amounts of inulin, which is the same fiber but longer, which has a slower fermentation. We add more of this. This is 1,3,1,4 beta-glucan from oats. And this is resistant starch from things like green bananas. The molecules are progressively more complicated, so they have slower fermentation rates. And you need to have all these different fibers, and you have them in the right proportions, because when this blend of prebiotic fibers enters the large bowel, everything is moving. And so the FOS starts this chain reaction first. It's moving the gut from being gram-negative to being gram-positive dominant, but it doesn't last very long. That's in the ascending colon, and then the inulin takes over, and the 1,3,1,4 beta-glucans and resistant starch. It's not as neat as this, of course. There's a lot of overlap, but it's really important not to use just the one fiber type on its own. You have to give prebiotic cover to the whole of the large intestine if you want to rectify the situation and move it back to some kind of pre-transitional, I'm talking about the dietary transition now, or the nutritional transition, going back to a time when the microbiota was healthier and we, all of us, enjoyed better health. So I've probably taken up a little bit too much time. Let me just stop the share at this point and throw this thing open for questions.
Hey, Dr. Paul, actually, I've gathered just a few things to ask about. And one of them is Dr. Imran. Dr. Imran, he asked, is there any evidence of molecular mimicry as a mechanism in neurodegenerative disease as a consequence of neuroinflammation?
Good Lord, that question went in an unexpected direction. I think I thought when you mentioned molecular mimicry that you'd be wanting to look at autoimmune disease. Could I ask the good doctor to amplify that question? I'd like a little bit more detail before I even try to answer it.
Absolutely. Let me just get him to unmute here. Just for some reason, it will not. There we go. Dr. Imran, it says, I did ask the unmute. You'll need to push the unmute button.
Yeah. Hi there.
Hi, doctor.
Good afternoon.
So, would you explain your question to me? Because I wasn't quite sure that I fully understood it.
Sure. Yeah. Sorry to bother you. Basically, what it was is that I read in there. I mean, I was just briefly going over your slides, and you did mention in the womb that there is a possibility of autism, and it got me thinking about the neurodegenerative, neuroinflammatory sort of mechanism which you described, and I wondered whether, because I know that there has been a link through autoimmunity where molecular mimicry has played a part. And I thought in your studies, when you've looked into this, that perhaps maybe that may have been another route by which this sort of kind of, manifests from the womb point of view. And I mean, of course, there's a lot of development going on in the womb at the time. So I just wondered if there was any crossover, or if in your experience you came across it.
Well, let me take those things in turn. In terms of the neurodevelopmental disorders in utero, and you're talking about really the second half of the second trimester and then the third trimester, and there's still some development going on, probably the first 18 months after birth as well. What's happening is, as the central nervous system is developing, you're getting all of these nerves, growing and finding the right way to the right places and making the right connections. And this is a very, very complex process. The nerves are following neurochemical and probably structural and possibly electrical gradients to find the right end organs. And then there's a process of consolidation, reinforcement, and pruning. So this is a very dynamic system that's taking place here. And the evidence indicates that if you superimpose chronic inflammatory stress on this, and interleukin-8 is in the frame, but it's not the only one, then this process of, first of all, cellular recognition, that is finding the right targets, is impaired, but also this whole process of pruning and synapse reformation is upset as well. So that whole process is so extraordinarily complicated that I think it's not surprising that the imposition of chronic inflammatory steroids is going to lead to an increase in the subsequent set of spectrum disorders. That is not just autism, as you know, it's also ADD, ADHD, Asperger's, dysphasia, dyspraxia, and a whole group of other disorders as well, and all of them seem to be increasing. If you look at all of the maternal risk factors, all of them seem to involve chronic inflammatory stress. That's the one common element that they all have. So I think that the case is quite a strong one. Then if we take a step back from that and look at the neurodegenerative diseases, I would say that the concept of chronic neuroinflammatory stress as a substantial risk factor for developing Alzheimer's and Parkinson's and MS as well, but we can talk about that separately if you wish. I think that the evidence there is very strong. Now, whether molecular mimicry is involved here, I think it's a whole different question. As you probably know, many immunologists would dispute the idea that molecular mimicry in the classic sense of autoimmune disease could occur at all. And I'm not an immunologist. I can't punch at that weight, but I do listen to them when, you know, people when they say that this doesn't make sense to us. And I think that the idea of dysbiosis leading to microbial translation and subclinical infection and intracellular infections subsequently being misdiagnosed as autoimmune, it makes a certain amount of sense to me. One of the reasons why I'm persuaded by that as a possible cause of autoimmune disease is, and you probably have come across this, is the successful use, which has been reported several times in the literature now, of long-term courses of antibiotics to treat autoimmune disease. And the interesting thing is, when you look at the antibiotics that were used in those studies, they are exclusively those antibiotics that we know are capable of entering inside into the intracellular space. Now, the problem with long-term courses of antibiotics, again, I don't need to tell you this, we don't like the idea of superimposing this stressor on the microbiota for long periods of time. That brings with it problems of its own. But there is a relatively recently developed antibiotic, which is actually it's effectively an amplification of a humoral component of the innate immune system, which has a very low molecular weight. That is, the active principles which are produced have a molecular weight of, I think, between 85 and 95, very low weight indeed. They cut through all physiological barriers like a hot knife through butter. And I'm in touch with a group of doctors who've been using these antibiotics to treat autoimmune diseases of various kinds with a great deal of success. Now, they're not reporting it yet, but it's going on in the background. And the reason why they're not reporting it is that this is not a pharmaceutically licensed antibiotic. It is actually an enzyme, lactoperoxidase, which of course you can't eat because you break it down. So you take the enzyme, you bind it to a solid substrate, you feed it its various the ingredients that it needs to do its thing. It produces the enzyme products, and you then drink it. Now, these are actually hypothiocyanous and hypothiocyanate ions. Very low molecular weight. They will equilibrate in all tissues of the body remarkably quickly. And because they're actually produced by the innate immune system anyway, that's one of your own key defenses, they don't impact on your symbionts. They have no effect at all. So there's no antibiotic-induced diarrhea, for example. So you don't have, you know, the serious problems that you have, for example, with clindamycin. That doesn't happen. And you can take this for long periods of time. I don't recommend you do this forever because these ions will have some oxidative stress. They'll confer some degree of oxidative stress. And there is probably over the longer haul, if you're going to go on to do this for months at a time, you may well end with oxidative related pathologies of one sort or another. But from what I've seen so far, it seems to be remarkably specific, remarkably effective, and remarkably safe. Does that answer your question? Oh, we've lost Dr. Rimmer.
Well, we were, maybe he was muting himself again here, but I think that was a wonderful answer. We do have another couple questions here about general gut health, and then we're going to
Okay.
ask some questions in regards to xenobiotic. Just maybe 5 more questions here. I hope you have time for that.
Okay. Sure.
So somebody was asking in regards to lectins and how they supposedly are also damaging the intestinal wall. And someone was also asking about oxalates. So things that are also damaging for.
Yeah, very sexy topics. Well, there's lectins and lectins. Most foods contain lectins. And, people are concerned about the Solanacea lectins, which may be a problem in some cases. Do they really damage the gut wall? I think that you'd have to be eating a very strange diet indeed to run into problems that way. The diets which contain higher contents of fruits and vegetables tend to be considered to be amongst the healthier diets. They will contain, in general, higher levels of lectins. So there doesn't seem to be a trade-off there. Having said that, all kinds of foods contain lectins, even some of the animal-based foods that we eat contain lectins. This is not just a plant metabolite. So I think on balance, I would say, well, possibly for certain subsets of lectins, because all these different lectins have different biological effects in the body. Some of them, if consumed in excess, may have adverse effects. But I don't think that this is the reason why we're seeing such an alarming increase in gastrointestinal problems in general, and immunological, cardiovascular, oncological problems. I don't think that's it. Now, with regard to oxalates, well, I mean, if you're eating your own body weight in kale and spinach every other day, and some people are very keen on doing that, you're probably going to be consuming too much oxalate. And amongst other things, that's probably going to cause, at a certain point, you're going to develop kidney stones. But it's not a good idea in general to be consuming too much oxalate. But again, I'd have to ask you, is this really is this a real question, or is it a theoretical question? Yes, you can poison yourself with oxalate if you ingest really huge amounts. That's one reason, for example, why we recommend that people don't eat rhubarb leaves, because rhubarb leaves contain very high levels of oxalic acid. But on the whole, people don't eat rhubarb leaves. So I think this is really more of a, I think it's more of a hypothetical than a clinically significant question.
Yeah, I got a question here from someone asking about what role does genetics play in your gut health?
Well, we know of certain genetic markers, certain genes, which do seem to produce an increased risk of different types of gastrointestinal problem. But my point would be, if you're going to bring up this whole nature-nurture debate, which is more important, the point is that probably all of these conditions have been around at a relatively low level for as long as humans have been around. But the trends that we've witnessed since, I suppose, the recent huge increase in most of these has been since about the 1960s. But if you go back further, you can see that they've been increasing probably since 1900. It's been so great, and it has been so universal in those groups of people who have moved to a post-transitional lifestyle, that is, who are no longer eating traditional diets, to me, it looks as if the environmental components, basically lifestyle, basically mostly diet, really swamp the genetic issues at a population level. Now, if as an individual you have a specific higher risk denoting gene, well, and that's unfortunate for you, and there may be ways of getting around the negative impact that that might have. But all I would say is that the cumulative evidence that we see from the epidemiology over the last half century, over the last century, if you go back to 1900, and I'm very keen on going back to the second half of the 19th century. It's an area that I specialize in. I think what that's telling us is all of these things have increased by leaps and bounds. Our genetic base at the population level hasn't really changed very much. So I think you have to look for environmental factors.
And we all have so much of that going on. We know so many people have such issues with their gut. And I truly believe, even if people don't feel that, there are, because of the way the world is today and the food that we're eating, probably everybody has this dysbiosis going on. Or am I wrong, Dr. Paul?
I think not everybody, but certainly the majority. I would refer back to the figures that we're seeing for NAFLD, where dysbiosis undoubtedly makes a contribution. It's not the only contribution. I mean, reduced levels of physical activity, increased intakes of sugars, they all feed into that. But I think that it's hard to have NAFLD if you don't have dysbiosis. I think it's an important contributory risk factor. And I think that what that tells us is that dysbiosis, certainly in modern urbanized populations, is the rule, not the exception.
Mm-hmm. Okay, so we are super proud that you have formulated this xenobiotic, because as you just explained, so many issues with dysbiosis of the bacteria. People are having such incredible stories from going from so many issues to having their gut healed so that their body can really work the way it's supposed to optimally. But there are questions in regards to getting started. When people get started, I have been recommending for a long time starting on because on here it says to take 1 scoop. But for a lot of people, they cannot be starting with 1 scoop.
I agree.
And they're having, otherwise, if they're taking too much to start with, they're having quite a few different things, whether it's stool issues of even if they're taking a lot of water. But so would you always recommend people to start on a smaller dose?
Well, in general, yes. I mean, once I'd formulated it, and I'm actually rather proud of it. It looks very simple, but it was very complicated to do because you had to get the different ratios right. You had to look at the different transit times in the gut, the different fermentation rates, and the different therapeutic indices. But I would say that for most people, I started off with a dose of, I think, just 2 scoops, because I already eat a rather healthy diet, and it didn't impact me negatively. It didn't have a huge effect on me at all, because I was already eat a lot of fiber. But I think for most people, if you have dysbiosis, you should probably start with a low dose. Start off with a 1/2 scoop or even a 1/4 scoop and gradually build up. If you have a really severe dysbiosis in the gut, it's a bit like Game of Thrones. You've got these so many different microbial species that are fighting with each other. They're competing. Sometimes they collaborate and take over from each other. And it might not be a very healthy situation down there, but it'll be what you're used to. So it's an unhealthy equilibrium. And if you start to interfere with that, some people can experience a lot of abdominal discomfort. They might have constipation or diarrhea. So start off with a low dose. And the other thing is that some people who haven't been properly diagnosed actually have SIBO, small intestinal bacterial overgrowth. And of course, if you have that condition, then xenobiotic and indeed prebiotic fibers of any kind are contraindicated, because you don't want to be encouraging the growth of good bacteria in the wrong place. And if they're in the small intestine, they're in the wrong place.
Well, they would be people that shouldn't need to or shouldn't be taking a prebiotic at all, xenobiotic included.
Absolutely. So typically they put on the FODMAP diet, which I think is rather, I don't think it's very well designed, but it will help, at least to some extent, but it won't remove the unhealthy bacteria from the small intestine. There's other ways of doing that. But
Is there
if
anybody else that shouldn't be taking xenobiotic?
if your colon has, if you've had severe IBD, or you've had a cancer in the large bowel so that the colon has been removed, then there's no point in taking xenobiotic. Not that it'll harm you, but it just won't, it'll just pass through you. SIBO is the main contraindication. If you do have SIBO and you start using xenobiotic or taking any prebiotic fiber, you're going to have pain, bloating, you're going to have all kinds of problems.
Now, just to be clear on this, is there a max that you can take? Because I know people that are doubling up on doses and making sure they're getting a lot to really strengthen their gut. Is there a reason to be taking more, or is it okay to be taking to be taking more xenobiotic, or is there a max?
Well, at a certain point, you're going to develop explosive diarrhea. It'll become initially a laxative, and then it's going to become purgative. So I don't think I mean, there's no reason to overdose. I think that for most people, if you get up to something like a scoop and a half, 2, so something like that a day, it's more than enough. We don't have to be like those Mesoamerican, Neolithic Amerindians. We don't have to go that far. But if we can go back to the mid-Victorian era, and that's a population that was actually very healthy. They had very little bowel cancer. They had some, but very, very little. They were consuming between 20, 30 grams of prebiotic fiber a day, and they were probably windier than we are. I mean, I remember reading a paper by an Indian doctor who had been looking at the original papers that were produced by Trowell and Burkitt, and any of the scientists who are out there, life scientists, know who Trowell and Burkitt were. And this Indian scientist said, well, in his opinion, if a healthy gut was actually a noisy one, and if your gut is too silent, that's actually a sign that you have dysbiosis, and that might be one way of looking at it.
Okay. Okay, so a healthy gut is a noisy gut. I like that. I like that. Maybe that would be a good thing to be finishing out on. There are some other questions, but I think we have used so much of the time here, and we know that this is something, and as you said, it was complicated to be doing. Actually, I do have one here that somebody was saying, because I hear this so many times when I'm out there, people say, well, I'm taking a probiotic. Right. Probiotic to prebiotic. So this is what I say, Dr. Paul. I say, well, your probiotic are the good bacteria. We just have such bad bacteria compared to the good bacteria. We want to feed the good bacteria. And that's what this can do, is feed the good bacteria to strengthen them. So if you're taking a good prebiotic, you don't need to take a probiotic. Am I saying that right?
Pretty much. I mean, I'm not convinced by the probiotics. Many of them don't survive gastric transit. The ones that do don't actually take, because you're sending very small amounts of cosseted lab-grown microbes under ideal environments into the gut, where they are encountering a very hostile environment, which is intensively colonized by a lot of other species that know the area, they know the terrain, they know how to look after it and themselves. And so you can take a probiotic, but it doesn't go anywhere, it doesn't stay. And we can measure it being excreted. But the day after you stop eating, what is it, Activia, isn't that the yogurt, or taking a probiotic capsule, within 24 hours of it, and when you stop taking it, it's gone. There's nothing left. Your endogenous microbiota throws it off. So the way to permanently achieve significant improvements in your microbiota is to use prebiotics. And unlike the probiotics, they're stable. They are, I mean, they're thermally stable. You can bake these fibers. You can take xenobiotic and bake it into cookies or bread if you want. They actually taste quite pleasant. has an infinitely long shelf life. I mean, I think it outmatches probiotics in every way.
And actually, I've looked at different prebiotics, and many of them just have a single fiber in it as a prebiotic fiber, where this is actually feeding every area of your gut to make everything healthy.
And that's really important. Yeah, if you're simply using one fiber, that doesn't reproduce the situation that appertained before the nutrition transition. It's not rocket science. All we're trying to do is to put back into the diet what always used to be there. That's all.
Mm-hmm. And to me, this is probably, I know that balance is extremely important, getting our bodies in balance. We do our balance test and our balance oil, but as you have said, it all works together, and the gut health is super important, and the xenobiotic is just as important, and they work together to make your body the best and optimal health that it can have, correct?
Well, that's the basis of the health protocol.
So last question, Dr. Paul. The change is that if we have people having health with gut health, what would that do and impact? What impact would that have on our, I know something, like your world health that you want to do something about? What would that do for everybody if we got more people, as many people as possible, getting their gut in balance?
I think that we could reduce the burden of ill health at the public level considerably. It's hard to be overly specific about this, but if you look at vestigial populations, if you look at pre-transitional populations, amongst groups that had a life expectancy similar to ours, they had a frequency of non-communicable degenerative disease that was only 10% of ours. Extrapolating from there, it looks as if we could reduce the burden of the NCDs, the non-communicable degenerative diseases, by up to 90%. Now, the World Health Organization, their meta-analysis showed that by eating more fiber, you could reduce the risk of early death by 30%. And I think that if you were to add to that the other elements in the health protocol, I think we could reduce early, i.e. preventable death, by anywhere up to 90%. If we could do that, we would starve the pharmaceutical industry. We'd be able to close down hospitals and cancer clinics, and we could transform public health, which at the moment is really distorted. It's distorted by political and economic factors. You end up with a system such as the one here in North America, which is absolutely dominated and regulated and controlled by the pharmaceutical industry, to the point where the regulators have been co-opted and compromised, and the politicians, like cheap whores, have all been bought. And then you end up with public health disasters, such as the response to COVID-19. No, we're in a terrible situation at the moment. And my argument would generally be that the obstacles between where we are now and very much better health, individually and at the level of public health, the hurdles are no longer scientific or technical. They're actually political.
Well, Dr. Paul, I know this is making such a difference for so many people's health. We have heard so many of the stories, and what you're saying about reducing that with so much, that's why we are passionate about getting the word out and letting everybody know what the health protocol really is about. So we want to thank you for taking the time to be on here. I will let everybody also unmute. And thank you, Dr. Paul, for your time, and thank everybody for joining us. Thanks, and have a great day.
Thank you so much.
Thank you so much.
Thank you so much.
Thank you.
Thank you
so much, Dr. Clayton.
Thank you, Dr. Clayton, so much.
You're very welcome.
Gracias, Dr. Clayton.
Holland. Thank you.
In English and in Spanish.
Gracias, doctor.
Thank you, Dr.
Obrigada.
Clayton.
Bye, Dr. Paul.
Yeah, gracias.
Thank you.
Thank
Dr.
you.
Paul, many thanks.
Muchas
Muchas
gracias.
gracias.
Obrigada.
Thank you.
Thank you.
Dankeschön.
We'll see you soon, Dr. Paul.
감사합니다.
Miss you, Dr. Paul. See you soon.
Merci beaucoup.
Bye,
Very
everybody.
grateful.
Słowacko.
Thank you.